Hello. I am Afrose.
I'm Amy.
And I am Shea-Lyn. Welcome to this presentation on the role of a dietitian in parenteral nutrition.
We are going to introduce you to Sally. She is a concerned family member who has some questions about her grandfather's parenteral nutrition for the registered dietitian.
We hope you can also learn something new about parenteral nutrition and the role a dietitian has in the process.
Hi Joey. You are a registered dietitian. I have a few questions for you. Last week my grandfather was admitted to the hospital and had to get a feeding tube put in. The doctor told me it is parenteral nutrition. But what does that mean?
Parenteral nutrition, also known as PN, is a form of feeding that delivers nutrients to the patient through an intravenous route. There are different forms of parenteral nutrition. The first difference is where the tip of a catheter delivering the nutrients terminates in the patient, centrally or peripherally. Central PN, the catheter tip terminates in a large vein, whereas peripheral terminates in a smaller, more distal vein. Central PN is often administered when it is required long-term, over 14 days, whereas peripheral PN is often administered for shorter-term cases. Another factor in determining where the IV will be placed is the concentration of the solution. If the patient has high nutrient requirements, or has a fluid restriction causing the nutrition solution to be more concentrated, central PN will be the location of feed. This is because central veins can handle higher concentrations of intravenous nutrients compared to the smaller veins in peripheral parenteral nutrition. Parenteral nutrition differentiates based on the contents of the intravenous solution. Nutrients given during parenteral nutrition include protein, in the form of crystalline amino acids, carbohydrates, as dextrose monohydrate, which provides the majority of the energy, lipid emulsions, that come in different forms, such as soybean oil, glycerol fish oil emulsions, are just a few examples. Other nutrients in the PN solution include electrolytes, vitamins, and trace elements such as copper, zinc, selenium, and more. Finally, parenteral nutrition can be used to supplement a patient's diet if they are not reaching their nutrient needs, or can also be used as their sole source of nutrition. When parenteral nutrition is the sole source of energy and nutrients, it is referred to as total parenteral nutrition, or TPN.
As a dietitian, what would your role be in helping my grandfather with his feeding tube?
That is a great question, Sally. Let me go through some steps I would take to help patients such as your grandfather with their nutrition. First, I would complete a nutritional assessment. A dietitian's assessment would analyze what the patient's nutrient requirements are, and to what extent they are meeting these requirements. Looking at lab values and patient history would also give me insight to their nutritional status and needs. This information would help guide my decision to advocate for a nutrition intervention, such as tube feeding. A dietitian can formulate a prescription, but needs a doctor's approval for it to be administered. We calculate our prescriptions regarding rate and nutrient needs, such as protein, energy and fluid. Dietitians do not manipulate micronutrients, such as electrolytes, vitamins and minerals without further training. We do not insert the catheter or begin the feed. We rely on other healthcare providers to assist in the nutrition care process. After the feed has been administered and is started, we would follow up with the patients to see how well they are tolerating it, altering the solution and rate as needed. We would also review lab values to monitor their status.
Now that I know more about what parenteral nutrition is, and how you as a dietitian would help with the process. When would you prescribe parenteral nutrition?
This is a harder question to answer, because it is not always clear. But there are a few things dietitians look for before prescribing parenteral nutrition. It is important to know that parenteral nutrition is not our first form of nutrition therapy we would prescribe. After realizing that nutrition support is needed, we would first consider oral and enteral routes. Because as a rule of thumb, if the gut works, use it. Dietitian consider supplemental parenteral nutrition to top up the patient's nutrition first, before suggesting total parenteral nutrition. However, if the patient has gastrointestinal problems such as an obstruction, a bleed, ischemia or other conditions that limit absorption of nutrients, then a dietitian would begin to consider parenteral nutrition more seriously.
What are some of the risks associated with parenteral nutrition?
Refeeding syndrome is one of the biggest risks associated with parenteral nutrition.
What is refeeding syndrome?
Refeeding syndrome is a serious metabolic condition that can be caused by the early introduction of nutrition therapy that can cause death but is easily preventable. Refeeding syndrome is a shift from a catabolic to anabolic state due to reintroduction of nutrition after prolonged starvation. When the patient is in a starved state, their insulin levels are decreased and there is a slight increase in glucagon and catecholamine. This metabolic state causes glycogenolysis, gluconeogenesis and protein catabolism. When nutrition therapy is introduced, glucose becomes the main source of energy once again. The reintroduction of glucose causes hyperglycemia, which results in an increase of insulin and decrease of glucagon. The body has now entered an anabolic state. The reaction to sudden PN causes a shift in fluid balance and metabolic state, which results in a shift of serum electrolytes. It can be seen in lab values to suggest hypophosphatemia, hypokalemia, hypomagnesemia, a thiamine deficiency or changes in glucose, protein and fat metabolism.
Oh no! What are you going to do to prevent my grandfather from getting...
The reaction to sudden PN causes a shift in fluid balance and metabolic state, which results in identify those who are at a higher risk. It can be seen in lab values to suggest hypophosphatemia, unintentional weight loss, hypomagnesemia, for at least 5 days, or changes in drug or alcohol protein and fat metabolism, and low levels of magnesium, potassium or phosphate before feeding. Patients that are at a higher risk of developing refeeding syndrome should have their PN administered at a decreased energy rate that is individualized and tailored to each patient. Later, the feed can be increased gradually over 4 to 7 days until their full energy requirements are met. Correcting electrolyte and fluid imbalances before feeding is not necessary and can be done along with feeding. In higher-risk patients, we also aim to avoid fluid overload by maintaining zero balance. Electrolyte levels should be tested daily for the first week of PN, and at least 3 times in the following week.
Monitoring electrolytes can be helpful in assessing the patient's body losses in order to make the necessary changes in their nutrition prescription.
Thank you so much for teaching me what dietitians do with parenteral nutrition and the risks associated with it. Thank you for watching our presentation.
We hope you learned what a dietitian's role is when administering parenteral nutrition.